we can have that available. Welcome, everyone, to an informal discussion on considerations in clinical care for people with autism and IDD. We have a short agenda. It's just this welcome. We ask that everybody mute themselves during the presentation. The next is a parent's journey. We'll have Stephanie James talking about her experience. And then we'll have Maura Sullivan, who will be talking about the program that she's helping to support at the ARC of Massachusetts. And then we're going to have a very robust Q&A because we really want to engage people in a discussion on next steps. And then we'll be closing. So our goal is to wrap up by 11 o'clock. So with that, I'd like to introduce you to Stephanie James.
Thanks,
Stephanie
Darla.
is a, yes?
Thank you.
I'm going to go ahead and just do a brief introduction for the purposes of the recording. So Stephanie is a parent advocate and a mother to an autistic daughter, Danielle. Danielle was an intelligent, sensitive, kind, caring, beautiful, and with a wonderful wit. Sadly, she passed in 2018 from medical neglect because no one recognized how ill she was. Her life can be a lesson for those in the medical field to learn how to listen better, care more, and respect the autistic individual. Stephanie will share a short version of Danielle's life to help get professionals to understand Danielle's health needs. With that, I'm introducing Stephanie.
Great. Thanks, Darla. I'm going to go off some notes so I stay coherent to all of you. So good morning. I want to share with you about my intelligent, beautiful, kind, caring, and witty daughter, Danielle. She always reminded me that life is about change. And so I hope this Zoom call with her story brings change to support autistic people and people with developmental disabilities in the medical profession. She loved life, my daughter, Danielle. She fought so hard to keep her life, always to the very end. Sorry. Danielle died in 2018 at the young age of 32. She was so proud to be a young woman, but her life was stolen from her by the medical establishment meant to support her needs as an autistic. Developmental delays had been present in her life from when she was 5 years old and had 5 grand mal seizures in 5 days. When she was 15 months old, she experienced these, and she was put on phenobarbital until she was 3 years old. She had numerous strep throat and ear infections and sinus infections, put on antibiotics many times over many years. She had her tonsils and adenoids taken out when she was 7 years old. Now we know from adult autistics why certain behaviors may have occurred. And we became aware of presenting behaviors as precursors to sinus infections. Without a lot of expressive language, she would self-harm or be aggressive to others or push over furniture. Being born in 1985, we didn't have the internet early on to share and compare with other families and do research. Later, I learned about interoception and vestibular and proprioceptive issues that absolutely must have affected her unbeknownst to us. An early speech language pathologist, an OT, identified her with sensory integration dysfunction, but little was known back when she was 5 years old, how to support her with this sensory processing issue. So it was amazing, due to her strong sense of self and wanting help, that she did so well. In the overwhelming sensory hospital stays, once for several days and nights for suspected sleep apnea, undiagnosable, but present in a lot of autistics, and once for a week for spinal fusion surgery for scoliosis. She was put on numerous psychotropic meds for, quote, behaviors by various psychiatrists, with diagnoses made inappropriately because they wanted to subdue her reactions to a noisy, contradictory world that didn't support her. Such meds were new to children and untested. None of them ever diagnosed her as autistic until I applied for Medicaid for her at age 18, and the psychiatrist said, clearly she is autistic. When Danielle was around 7 years old, she and we, her parents, met with a medical team from CU Medical Center, composed of a pediatrician, psychiatrist, and a behavior specialist. This, quote, state functional analysis team / behavior pharmacology clinic, end quote, could not diagnose her. For many years, medical people went by or referred to her educational label of PDD-NOS, meaning pervasive developmental disorder not otherwise specified. This never led to the appropriate support she needed. She went to the ER many times, ending in stays at a local hospital and to Children's Hospital and Cleo Wallace under abhorrent conditions, to where we brought her home, seeing them as examples of malfeasance in the medical community and that she was safer at home. The final insult to my daughter Danielle was the delay by the medical staff at her state group home in sending her to the hospital for 2 weeks, as she clearly presented with C. diff. When she was in the ER, I had to pull a nurse aside and explain to her that Danielle was autistic and the environment was sensory overwhelming, as the nurse was using inappropriate language to my daughter. Danielle died after admittance to the hospital, with ICU doctors shocked at the delay in getting her appropriate care. She died in acute agony, denied morphine with a substitute because, quote, there was a shortage. I have always wondered about this and should probably do some research on morphine shortage in 2018. The night before she died, we, her dad and I, were told if she survived the night, her hospital team wanted to try a new surgery using fecal implants. I prayed for her to survive, but I also thought, as an autistic, just learning about interoception and how it impacted her personally, how would she deal with this major surgery and recovery? Danielle died 3 days after admittance. The ICU doctors were shocked at the delay in getting her appropriate medical care. She died a very painful death. She was autistic and died because she was autistic. I miss her desperately because no one heard her, listened to her, understood her, and respected her enough to learn about autism. Thank you very much.
Wow. Get the tissues out, everybody. I'm so sorry. Anyways, we're going to go ahead next with with Maura, who's going to talk to us about the possibility of really creating a more standardized and robust training that's been done in Massachusetts. So Maura is a dedicated and passionate leader in advocacy for people with autism and intellectual and developmental disabilities, with an expertise in disability health policy and education. She's a registered lobbyist at the with the ARC of Massachusetts and in Massachusetts, and represents advocates for autism of Massachusetts on legislative priorities at the State House. She collaborates with key community stakeholders to impact bias against people with disabilities, including her work on training medical professionals through the ARC of Massachusetts consideration in clinical care for people with autism and IDD. Her life focus for this work comes from being a mother of 2 young men with autism and intellectual disabilities. Maura, I'm going to go ahead and give you the opportunity to share your screen. Maura has a PowerPoint that she's going to share. So hold on here. Let's see. I think I'm going to give you the opportunity to.
I think I see the share screen button, so I should be
okay. Perfect.
Yeah. Thank you so much for that intro, and Stephanie, thank you for sharing your story. It's so powerful. It's so devastating. But from this is, where we can begin to make change. And I appreciate everybody being here today and just to hear a little bit more about Operation House Call in Massachusetts and how we've grown the program. And so I'll just jump right in. I'll share my slide, and it does say I'm disabled after all that. Okay, so you just have to make me a host or a co-host. I think if you click on my name under participants, and then you just say make me a host or a co-host.
You would think that after all of the Zoom meetings that we've all been in since the pandemic, that this would be easier.
Every time they change things, I get messed up,
Let me see. So I'm going to click on your name.
And then
And it's so strange. It's only giving me an invite. So that's not really what I want to do.
yes.
And well, it says multiple participants can share simultaneously. So see if that worked.
Okay, let's see. Yep, that worked. Ooh, I have a lot of stuff up on my slide there. Hold on, let me scroll up to the top here. So yeah, I love talking about Operation House Call because it is absolutely my passion, although you heard that my main job is government affairs. So I try to kind of balance both of the two, and we actually have legislation around Operation House Call, a bill. So I get to kind of work on both. But anyway, you already heard about me, but I do like to start with this picture of my son, Neil, because it reminds me of the importance of our communication, our bond around communication. And so I'll just jump right into a quick story about Neil. He is not verbal, and a little bit like you heard about Stephanie's daughter, he sometimes has a lot of behaviors to try to communicate, and all of his behaviors are pretty clear communication efforts. But this one particular morning, he woke up and he was just way off his baseline. I mean, I knew immediately that something was really wrong, because even when Neil is very, very sick, with a fever or a virus, or he is not lethargic, and he could not lift himself or his head off the pillow, and his eyes were, rolling back. He was just absolutely not himself. And I just immediately brought him to the emergency room. He has a lot of medical complicated issues. He's got mitochondrial disease, epilepsy, and at the time he had Crohn's disease. So we had a lot of issues to try to figure out when he was acting ill. Anyway, I got to the emergency room, and, we had our usual extended wait in the waiting room and challenges there. But when he did get in, they kind of gave him a very cursory exam, barely touched him actually, but did get blood work because he was so out of it. He didn't care at all. He just let them take the blood. And they did give us an IV, and he, again, tolerated that fine. And the IV sort of plumped him up a little. He opened his eyes a bit more. And when he opened his eyes, I mean, every time he looked at me, there was just such total desperation in his face. And I tried to communicate that over and over to every nurse and doctor that walked into the exam room. But before I knew it, all of a sudden they were handing me discharge paperwork, and they said, this is likely a virus, keep him hydrated, goodbye. And it went against everything, all my instincts, but I kind of walked out, kind of helping him out the door. And I remember sort of lifting him. He was 14, still pretty big. And I lifted him into the minivan seat, and he grabbed my arm, and he looked right in my eyes. And, with his eyes, he said, "No, Mom, no. Something's really wrong. Don't take me home." And I got the message, brought him back in. We had another extended wait. I faced a lot of kind of eye rolls at the administration desk. But when they finally took him back in, they did do a CAT scan, and he had a perforated appendix and needed an emergency appendectomy. And we spent, the next 5 days in the hospital on intravenous antibiotic. And we were lucky that, they were able to get all of the burst appendix. but I tell this story not because, oh, I always know when something's up with my son and doctors should always listen to me, because I don't, and we get it wrong a lot. But every time him and I work together to communicate to a doctor, they need to listen every time, because it can be life or death, right? So I also worry about families, parents, caregivers who maybe don't feel comfortable bumping up against the system, or they wouldn't have brought their kid back in, right? Because they were clearly discharged and given that order. So we want to see our doctors and nurses pay special attention and especially learn to partner with caregivers. And the other thing I think that clearly could have happened is if any one of those nurses or doctors took a little bit more time, and I know was an emergency room, but literally a minute to connect with Neil himself, to look in Neil's face, I think they would have seen the nonverbal communication that I saw, which was a total desperation and please, please help me. They would have seen that kind of pain. Normally when Neil's in pain, he's self-injuring, he's aggressive, he shows his pain that way. But this was something really different and difficult for me to figure out, but we knew something was wrong. So anyway, I like to tell that story because it reminds me more than anything of why I do this. But now we have this wonderful program here, and I'll just give you a little bit of an overview. Right now, we are in every medical school in Massachusetts with our program called Operation House Call, and it's run out of the Arc of Massachusetts. We've been doing it here for about 10 years. I started actually part-time doing Operation House Call, and then my executive director here brought me on full-time to do government affairs and continue to work on Operation House Call. So over the years, what we've done is we've grown the program at our medical schools, but in order to do that, we had to grow the families that participate in this program. So we have over 250 families, and I'll tell you all about the program, but they really are the heart of the program. They welcome students into their homes, and students get experiential learning. And this is, the most powerful part, learning directly from individuals with autism and IDD and their families, parents, siblings, other caregivers. And students grow mostly, I think the point is just to grow some interest. We want these students to be not just willing to take patients, which we really need, but, really interested, curious, and confident that they can do it. Because what we know is that there are some significant health disparities that exist, right? You all know this. And there's also some very significant access issues, especially for our adults. So if we can grow some confidence, some willingness, some interest, we're hoping we can affect access issues and begin to affect some of those health disparities with our curriculum, with our learning objectives, and with them learning experientially from families. So we also know that implicit bias, which exists, and sometimes not implicit, but explicit bias exists, and it affects treatment and assessment. And we see that through something called diagnostic overshadowing, where all they see is the diagnosis. They don't bother to look beyond it. We see that in terms of just attitudinal barriers that really affect inclusive healthcare in general. So let me tell you a little bit about the program. It is a lecture in every school. The ideal lecture is 2 hours. We hope to get 2 hours of time. And all of our schools except one right now gives us 2 hours. And I'll talk to you a little bit more about like the challenges of working with the schools. But So during this 2 hours, we have parent instructors. So every instructor is a parent who has a loved one with IDD or autism. And we teach our learning objectives through our personal families' stories. We usually try to have 2 teachers who have a little bit different backgrounds. So like for me, I have 2 sons with profound autism. One of my sons that you heard about already, he's not verbal and he's really medically complex. And then I have another son who's a little bit younger, who is just has some language, but he's pretty much nonverbal as well, not as medically complex, and does a little bit better job communicating on his own and telling us his needs. Like if he's in pain, he can communicate that. So 2 kind of little bit different kids in the same family. And then, I would typically have another parent instructor who has a little bit different experience. Maybe they have a child with mental health issues that intersect with autism, or, a person on the spectrum who has really, severe anxiety plus autism. Or we might have a family who has someone with just intellectual disability and a genetic syndrome, and maybe less behavioral issues. So that's the parent instructor piece. And we, again, teach our learning objectives, but always through our personal stories, kind of like the story you just heard me tell about my emergency room visit. But we also try to hit on some important things like those health disparities, and that they exist, and that attitudinal barriers can really affect care. And then we bring in another really great part of the program is we bring in a panel of individuals with autism and IDD and their families. And so most classes have 2, sometimes we'll even have 3 individuals that come in. They'll tell their story, and then we open it up for the students to just have a really kind of open Q&A where they practice communicating, they practice building rapport with that individual, whether it's communicating directly with them, whether it's communicating kind of with them through their caregiver, and just really getting to know, what life has been like for them, the journey, what's been easy and wonderful for them and typical and ordinary, and what's been extraordinarily challenging, what works with their doctors, what doesn't. So they get a little chance to just, really feel comfortable. And I think after that, like 45-minute, half an hour time frame, the students really do have a feeling of comfort. I think that's enough, because now with just that little bit of comfort and a little bit of foundational learning from our lecture, they're ready to go meet with families and really dive into these home visits, which are actually now virtual, not as powerful as they have been, over the 8 years that we were doing them in person. But they're still really great. And I have to say, it's been a little bit easier for families and for the students, obviously, to do them virtually than to have to get in the cars and coordinate with each other. But the visits we take the students and we pair them up, or in some cases we might triple up a student group, and then we assign them to a volunteer family, and we give the students a short profile on the family, and we connect them through email. And then from there, it's up to the students and the family to make a time for a visit, whether it's virtual or in person. And then the students have this nice, really comfortable time where the roles are reversed, like the students are there to learn, they're there to observe, they're there to take it all in, and families are the teachers. And I will say, one sort of side benefit of this is that individuals and families become stronger healthcare advocates through this program. They, you know, talk to these students on the weekends, and they suddenly say to me, you know, I'm a better advocate for myself now that I practice talking to these students. And then, of course, the students come away with just incredible insights. They are really changed by these visits. And I hope they're also changed by the class. I think their eyes are opened. They begin to see the strength of the individual with a disability and the absolute resilience of the family around them. And I know that because then these students write about their experience, and they write a self-reflection essay in a privacy protected forum that we keep up, and they're powerful. You know, they are in awe of what the families have been through. They're sometimes irate about the stories they hear. They show just so much compassion for what it takes to raise a child, or to live every day with a disability. But they're also just really inspired. They're inspired, and they learn a lot about the education system from the families, and you know, what supports them and what challenges they have. Even in the community, families will talk about the bias they face. So it's just such a well-rounded way for them to learn about what we go through in day to day. And then the other great part is they hear the stories of incredible champions that they've, you know, families have interacted with, like wonderful doctors who have learned over time, or, you know, a doctor they ran into who did something amazing and it's stayed with the family. So anyway, our parent instructors then actually respond to the self-reflection essays. So we kind of process them with the student. So if they had questions, or if they saw something that was, you know, unusual, they needed more explanation of it. That's where our parent instructors will write back on the forum. They will give additional resources. Our website is full of really great clinical resources and family perspective resources. It's a little hard to constantly keep them updated, but we're trying to be as up to date as possible, like changing our curriculum with COVID, and changing our curriculum to kind of address more intersectionality issues that have really come up. And diversity in general has been a little bit of a challenge for us to bring into the program. So working on that constantly as well. So those are all our schools: Harvard and BU and Tufts and UMass. And we are so lucky. We also have Simmons Graduate Nursing School on board, and UMass Graduate Nursing School. And they are wonderful students to teach. I would say they're almost a little bit further along than the medical students in terms of understanding of people with disabilities. Maybe they have a little more background or even work experience before they go in. But it's just, so those are all of the schools and all the people we reach. And I'll make sure I'm staying on track here for time. So yeah, so these are the learning objectives. We spend a lot of time on communication and the importance of respecting nonverbal communication, you know, looking at that whole person instead of just seeing the diagnosis. We talk about the importance of talking directly to the individual who has the disability, regardless of whether they can speak back to them, to make sure that they're giving plenty of time for an individual to process a question, but that they're also opening it up and understanding that, you know, they want to hear from their patient, but there are other important voices in the room, and really giving it to the patient and their caregivers. What works best? Give me some insight. Tell me how to manage this. And just pretty much on anything related to communication or sensory issues or any of the things that might come up, to really not be afraid to give it back to their patients and families to say, help me. Tell me what works best. I'm here to learn. and to not feel bad about that, and that this is a really complex sometimes, and learning from your patient each and every time is so important, and it's really an art. So we'd spend, I would say, majority of the class talking about different communication strategies. We also talk a lot about tips and accommodations, and we get, our 250 families to kind of weigh in, and we give them this nice tip sheet as part of their curriculum materials. So we talk a little bit about, what tends to work well in an office visit and what doesn't. And we've been bringing in a lot about intersectionality, because we know, people of color who also have autism have even greater health disparities. So we try to bring that in as well. And then we talk a lot about monitoring bias and diagnostic overshadowing. I talk a lot about my sons, early on. Neil and Tyler both had a lot of self-injurious behavior. A lot of my son would do a lot of punching of his chin, to the point I couldn't, stop him, right? Even when he was small. And we would go to the emergency room or to a covering doctor or someone new, and they would say, oh, this is part of his autism. And, you need to see a good psychiatrist and get him on meds. And he needs therapy, get him behavioral therapy. And, I agree, all those things can be really important. But what was really happening with Neil is he had severe reflux. It was coming up from his lower intestine. It was basically hitting a raw esophagus. And he was punching and twisting and doing whatever he could to try to alleviate that pain. He wouldn't sleep at night because laying down would bring that acid right up. And so, just making sure that we do not overlook those medical issues that can be, the real cause of certain behaviors is so important. So we tell a lot of stories like that. And I have a young woman who, went 17 years of her life incontinent, and they just blamed her autism. The doctors never looked at a structural problem that could have been causing it. And it was just a life in a public school in an inclusive setting where she was just constantly humiliated by her incontinence. And finally, some doctor said, let's do some tests, and found out this was never her fault, but they said, it was just her focus. She was too narrowed in on what she was doing to feel those, sensations that she had to go to the bathroom. And so it's just kind of telling these stories and bringing out, the way that they can look beyond those things. So that's a little bit about accommodations. And do I have a few minutes to just tell a quick story about, and this was, part of something you might have already heard on some of the other things you've watched, but this is another important area that we talk about, being that there are champions out there, and we really want to see every medical student be a champion for people with disabilities. But I had this one experience with Neil where he was really struggling in the emergency room. I had to bring him. It was many days of him very, very upset. And I was working with his medical team back and forth, and they were telling me, try this med, try that med. But eventually we had to go. And Neil was really aggressive in the emergency room and very, very loud. And finally, a patient in the ED stood up, and he looked right at me and he said, you ought to have to put a muzzle on that thing. And I remember, feeling I was exhausted from 4 days of Neil crying. And I thought, I don't have a drop of strength left. And how am I going to get Neil through today? And how am I going to get Neil through life? And this doctor had been nearby. He escorted the patient that was making that rude comment to another waiting room or something. But he came back out, and he came right over to Neil, and he said, "What is your name?" And I said, his name is Neil. And he said, Neil, I'm so sorry that you're hurting. And I'm sorry that you have to wait. But I'm going to help you. And I'm going to help your parents because you deserve it. And, people were listening. He looked around the room. He made eye contact. He did everything to change the culture from intolerant to total compassion. People were coming up to me and, oh, that guy was a bully. Do you want to use my kid's iPad? And nurses and other people were asking, how can we make Neil comfortable? How can we help? And, Neil didn't calm down right away, but I certainly got back every bit of my strength that I needed to advocate for his healthcare. And honestly, it kind of was something I needed just in general to get stronger. So I feel so grateful to this doctor. And I tell my students stories like this because I want them to know that they are in that position to make a huge difference. They can do this in their offices. They can do this anywhere they're practicing. They can do this in life, and they will make an impact on everyone around them. This man changed the culture in an instant, and I'm sure he continued to do that everywhere he went for people. I worry about Neil, though, because he was a cutie when this happened, a little guy, but now he's 21 and he's almost 6 feet tall, and he still has these same behaviors. Would a doctor stand up for him now? What if we were non-English speaking or Black, or Neil was 45 years old? Would someone come in and be a champion for him? So I encourage all my students to be that champion. But anyway, that's just a little bit more about the disparities we talk about. And the rest of my slides are really more like we can talk about during Q&A. So it's just kind of how to get started, some tips, and I'll send these to you, obviously. And then how to build this family network that's so key. And it might seem like a lot. It might seem like overwhelming to start a program like this. But the good news is you can start it so small. It can be 10 medical students as a pilot program in one school, or 10 nurses, and then you need 5 families to help you to volunteer. So that's very doable, right? And then the challenges are really getting in there, getting into the medical schools, getting some time, getting them to commit to a pilot. Once you get a pilot and you have done work with even a few medical students, the students will help you get the program going as well. But yeah, there are a lot of barriers. They may not think it's important enough. So, working with champions who are already out there providing care for people with autism and IDD is a great place to start. You might have an autism clinic at a hospital, get that doctor on board to help you to write letters. And then, the other barriers that we face are definitely around payment, because, we end up with, very little stipends from these medical schools. And it doesn't cover the costs typically, until we really get in there and they really see the value of the program. And when they start to see the value of the program, things start to change. So that's really, I can stop my share now because I think I went over my time, but I want to make sure we have lots of Q&A time too.
Well, thank you. And because we're such a small group, I think if you want to just raise your hand and I'll call you, because that way we're not all speaking over ourselves. But we'll start with Stephanie. Stephanie, you have a question?
Thank you, Maura. That was fantastic. And it gives me a lot of hope that we can bring this program here to Colorado. I really want to start with the hospital where my daughter was admitted. because I think that they would really listen well. I've been a patient there recently, and I found that they are very caring and they're part of the community. And I would love to learn how to bring that to them. I have some contacts there, so that would be fantastic. My other question is, do you do data to follow up with these students once they're professionals in their fields, and how they're utilizing the skills, the tools that you taught them?
Yeah, so on your first part of your comment, I would say, absolutely go back to that hospital. It's like you have such a powerful story. And if you feel you have champions there, the one thing that we have kind of learned over time is practicing providers is so important. But we have better luck doing our program, obviously, with medical students, but getting those providers to kind of lead you back to the medical school, because most of these medical schools are affiliated with the major hospitals.
Okay.
So that's a good place to start. But if you're interested in just training these doctors in the hospital and these nurses, and that's totally doable too. You're probably not going to get like the home visit piece. They're just, it's really hard to coordinate that when they have their busy lives, and, they're not required as part of school to do this. But we really successfully did some trainings in the emergency departments here in Massachusetts, actually, and in New Hampshire. Similarly, we had some really traumatic and challenging situations during COVID, which actually brought the ADA coordinators, the Americans with Disabilities Act coordinators at the hospitals to us. And they said, we have all these complaints, and we need to do trainings as corrective action. And so that was a great opportunity to bring our lecture to the hospital. And we did do them online then, and it was like really efficient. We were able to reach 300 doctors throughout this, which was incredible. They were kind of forced to be there because of corrective action issues from the hospital. The hospital really, the ADA coordinators really helped with that. So you have lots of options in that way, but I would say to build like a program like Operation House Call, the medical school is the place to go. And then your other question was, sorry.
That's okay. The data, do you have data to follow up?
Yeah, so we struggle with that piece on outcome measures. We do have these, wonderful self-reflection essays, and this is how we kind of measure our success at this time. And we have been able to do one more long-term study where we took the emails of students that have been through the program and did a massive outreach. We were then sort of told, you're not supposed to use those emails because the medical schools have the rights to like those emails in some way, mostly for fundraising, I think, for alumni fundraising. But we snuck it in, and we did get one study done, which was great. And we were able to ask, so we have some outcome measures from that. We asked like 4 basic questions around whether, the Operation House Call experience made a difference in their practice today, made them more willing to treat patients, anything like that. And we certainly had excellent outcomes there, but it would be really nice to see, a broader study done, and to somehow see like even out 10 years, do they even remember us? I was disheartened to find that we do a police training too, not me, but another organization. And, it's a really powerful 2 hours of training these cadets. And then, 5 years later, we were sitting in a room with all the cadets, and many of them didn't even remember the training that had occurred. And I was like, oh no. So that to me, that states that we need to train in the medical school. We need to do more training in residency, and then we need to have these continuing education opportunities, no matter what. So we're kind of, we've made a dent, but there's so much more work to do.
Thank you very much.
Yeah. Hi, Kristen.
Unmute myself. Well, first of all, this is so exciting and thank you for inviting me. I'm Kristen, my pronouns are she, her, and I'm autistic. I'm also a patient advocate in a clinic. So I'm wondering, on your instructors, do you have autistic adults as instructors, as well as the parents? Just because I know, some of the things I've experienced in my own healthcare. I've learned that I have to go in and mask like so hard, and I don't tell people my diagnosis, because then that's all they'll see. I even like hesitate to say generalized anxiety that goes along with my autism because that's all they'll see. Yeah. So I just, this program sounds amazing and it's really exciting. So that was my question. Do you have autistic adults as instructors alongside the parents?
Yep, and we do, and we call all of our teachers like co-teachers because we're all teaching. We're parent teachers, we're self-advocate or individuals with the disability teaching, and I recently brought on someone who I call my ambassador, and he is an individual with autism. He's also been through just an incredible journey because he also had cancer. So his medical journey has been really intense, but it's wonderful for the students to hear directly from him. And I have many other individuals with autism, and I also have an instructor, a co-teacher who is 48, and he has autism, and he is just amazing what he can teach these students, and they are glued to him. So it's wonderful. And we do try to make sure we have a balance of stories, of good stories and challenging stories, because the one thing you don't want to do is leave the students feeling almost like guilty for their profession, right? Which it can happen, and then they get a little defensive, and we don't want to do that. So it's a really delicate balance of doing that. But yeah, it's been really powerful. I think anxiety is a huge issue for us to make sure we teach better around. I think the challenge though is that it's hard to fit everything into one class. There's so much to teach, and after every class I feel like, oh, we missed teaching about that, we didn't catch this, or like that story that I normally tell, I didn't get to tell, or my self-advocate that is, usually makes such a good point on that. So we always have this opportunity to follow up though, which is really nice. We have all the students, we have all their emails, we have this wonderful forum. So, there's more to do, and it's such a broad spectrum, right? But we're getting in there a little bit anyway.
Yeah, this is awesome and exciting. Thank you.
Thank you.
Thank you, Kristen. I really appreciated your question. I was hoping somebody would ask that.
Well, Stephanie, I also wanted to say, let's touch base after, because I would love to be a part of what you were talking about with the hospital, in our area. I'd love to talk about what we could do.
Thank you. Yeah, and I'd like to learn more about what you do.
Awesome. That is a great interchange. That's exactly what an informal discussion is about. So I'm excited. Stephanie, the other Stephanie, we have two Stephanies.
Yes.
Oh, you're on mute, Steph.
I thought I hit the button. So thanks. Thank you so much for sending this invitation out. It's of personal interest to me as well. I also have a son with autism who's now 40 and had similar experiences as he was growing up. Ironically, his father, my husband, was a child health associate and went to school at CU Med. And his training was a field trip to Wheat Ridge Regional Center, which was all adults. And his field was pediatrics. So, I guess there was an effort, at least in the early 1980s, We've done trainings here. One of my board members, Dr. Salvatore, was running the intern program at one of our hospitals here in Pueblo, Colorado. And we would go and meet with each class that she would receive, which was great. But you're right, it's the students where you can have a little more control in their curriculum. And I absolutely love these family stories. I've been making notes like crazy. So I'm going to reach out to Dr. Salvatore. I think I'm going to reach out to CSU Pueblo, who has a nursing program, which I think could also be awesome with this kind of curriculum. So please keep me in the loop with whatever Colorado's efforts are. I think the former Lieutenant Governor Joe Garcia, who's now the Chancellor of the Colorado Community College System, and other contacts that we have might help us get this embedded more in our colleges and universities in Colorado. With that said, I have to run to an 11 o'clock meeting, but please keep me in the loop, Darla. It was so good seeing you again. Take care, everybody.
Thanks, Stephanie.
Thanks, Stephanie. Any other questions? Sarah? You're locked from, oh, I can't.
From commenting or joining
Oh.
the conversation.
Okay, so is it something I did? Oh. I retired earlier this year, so I know I don't know how to use the button so well, so maybe I thought I did something. Do you want to throw your comment? Can you put it in the chat? Oh, you don't?
She
Oh,
can't do
okay.
it. That's okay. Can you guys read that?
Later I'll send notes and questions.
Okay.
Thank
Okay,
you.
that's fine.
Any other questions? Comments? Carrie?
So
Yeah, I don't really have any questions. I think what you're doing, Maura, is fantastic. I'm hopeful that we can get a training like this going in Colorado. I picked up a lot of what you said and how you're managing the trainings and the different parts of it, the panel, the parents, and how they're very impactful. We're currently working, and we have been for a long time, on police training. And we have some recent legislation that is mandating further police training in Colorado, and thank goodness. So we are busy with that. We have 7 districts in our county, and we're super busy with that, super excited. But I took a lot of what you guys have included in your training and made a lot of notes of how we can strengthen ours. So I appreciate that. I really, really like the self-reflection piece that you're doing at the end too. I'm going to incorporate that, I think, into our police training as well. So thank you for that.
Oh, great. Yeah, it is really a great piece. And I hear a lot like medical students don't write anymore. And so when they have an opportunity or they're, told to write, some of them really want to do it. They haven't written and they just pour their hearts out. It's incredible. So I do have a young medical student who's interested in looking at the literally thousands of essays that I have over the last 10 years, putting them into some kind of software and doing some analysis. So we'll see. Hopefully something amazing can come out of that.
Thank you.
Dolly, did you have any questions? Because I see you're covered up.
Yes, I was trying to make myself presentable, but it didn't work. I had dental surgery yesterday, so there's no way to cover up.
I have some
the
tomorrow.
chipmunk face went through. Yeah. One of the things that I have to tell you is, I've been in healthcare since 1980, and regardless of what the situation is, whether somebody's autistic or Alzheimer's or whatever issue they have, it is really helpful if you have something that you can present to the healthcare worker that says, this is my story. This is how they communicate. This is how they react. This is what, the hitting of the face means there's pain, so that people can pay a little bit better of attention. When I think of the stories that I hear, there are some universal things that that just kind of blows my mind that people didn't pick up on. You know, a temperature, the C. diff. I mean, there is something about C. diff that once you smell it, you know it immediately. So there is no question. And so those kind of things just really bother me, that people didn't utilize their critical thinking skills in the broad scale that we have for every individual, not just specialized disabilities. And so there are some things that you know are wrong when you take a look at an individual. And so it's really disappointing for me to understand, and I guess I don't understand. And just to make a comment, and Darla will remember this, is that finding that group of healthcare providers who really want to be your tribe. So years ago, when I was on the Arc of Aurora board of directors, we had a gentleman named Ben. Ben loved cows. Ben needed to go to a long-term care facility for some short-term rehab. So I went and I was helping set up his room because he was going to be there for Christmas. And he kept calling me a cow. And the people were like, wow. And I mean, I'm not tiny by any means. So it was like, you know, they were looking at me, they're like, wow. And I said, no, you need to understand, Ben's favorite animal is a cow. And the guy who was with therapy, he said, you know what, that's great to know, Dolly. We're all going to strive to be a cow. And so he understood the importance of that right from the beginning. So hopefully, you know, people can be taught to want to look at those things and say, you know, I want to be the cow, or I want to be the superhero, or I want to be able to sit back and observe and make you comfortable in a situation, because they really don't teach, you know, they gloss over it in nursing schools, where you talk about autism, you talk about developmental disabilities. You know, everybody thinks that a psychotropic medication is going to fix everything. And if something is a personality trait for an individual, you can't medicate personality traits. You have to observe them and work with them. You have to figure out how to work with that individual. And sometimes, you know, and you all know this, people don't take the time to do that, because especially now after COVID, I was just in a long-term care facility where I was one nurse to 33 patients. And I passed all their meds, I did all their treatments. And I did have an individual who was 32, 33 years old with autism. He had a medical need, but they were like, oh, we're going to keep him long-term care. I said, this is not the appropriate living situation for a 32, 33-year-old gentleman. So you all need to know that, first of all. And I was just talking with, and I'm sorry, I forgot your name. I took my glasses off.
Stephanie.
Put the glasses back on. Stephanie. Yeah. And we were talking about the fact that to find the appropriate placement for individuals, it has to start right from the beginning. You know, before the person is ever discharged from a hospital, if they need rehab or long-term care for a short-term setting, it needs to be said right up front, this is not a long-term placement for the individual. So let's get that started right now. Let's make sure that everybody understands that even though they have this short-term housing situation, we need to continue finding them long-term housing in an appropriate setting for their age group. And a lot of times that discussion doesn't happen because the hospital says, oh, we just want to get rid of them. A long-term care facility who's probably very crappy. And that's why they said, oh, we'll take this high dollar Medicare person, because, you know, if you have behaviors and you have a medical need, they make big money off it. And so they're looking at making money. They're not looking at making someone's life better. And so I don't know what the answer is to that, other than it has to be a discussion right from the beginning with a social worker at the hospital, to understand that we still need to continue. And here in Colorado, we have community center boards. So we have to get other people involved in finding appropriate placement. And there are emergency placements here in Colorado. So it's not like somebody has to be on a waiting list. One of the last things I did as the state president of the ARC of Colorado is we filed a lawsuit against the state of Colorado for the waiting list in the 1990s, saying that that is illegal. You can't have a waiting list for services. You know, so you have emergency slot services, and community center boards have to help in finding appropriate cares for these individuals. And so that's all I had to say.
Well, thank you, Dolly. I think we're coming up on 11, a little bit after 11 o'clock. I just wanted to talk about next steps in closing. And so this is the beginning of a discussion. It's not the end of a discussion. And I'm happy to support facilitating getting the recording of this training on QMAP Academy's website, qmapacademy.com. And I'm only putting it there because I'm not affiliated with an ARC anymore. I retired earlier this year. And so that is a small business I have with my sister, who you just heard, the nurse. And then we'll make sure that the PowerPoint is there. And I'm happy to help support next steps. I think this is an important dialogue. And I know that organizations that do advocacy do their planning at the beginning of the year. And this is the middle of the year. And it might not be an important discussion because they've got a lot of things on their plate. But if we could begin to proceed with some kind of opportunity through maybe an organized program who could help facilitate those next steps, that would be great. My experience has always been that if you have an organized effort through an organization, it makes it easier for it to be determined credible, which has nothing to do with credibility.
Right.
I'm by no means speaking towards the power of those people who showed up today and their stories. So with that, are there any additional questions before we end? I'd like to thank our presenters. This was so informative. My heart is still in disability and advocacy, so I appreciated the opportunity to learn again. Thank you, Stephanie. Thank you, Maura. Thank you for those who attended.
Thanks for having me. And I just wanted to say, I sent along the PowerPoint, but I also have other materials. I'm totally willing to share, like our tip sheets, how we communicate. If you guys start moving, kind of like how we communicate with our students, I can give you templates. I'm totally willing to share anything.
Awesome. Well, I am going to go ahead and put it on the website, but if you don't have my, I'm going to give you qmapacademy@gmail.com. That's the company's email address. I've been communicating with my personal one, but I'm happy to shoot me an email, and I'm happy to share whatever I get, since this was not, again, one of those things where you registered and we kept track of your email addresses, primarily because I have no capacity to do that, but also it was just the first step. So shoot me an email at qmapacademy@gmail.com, and I'm happy to forward whatever I get, and also to pass on if Stephanie and Maura, if you don't mind, if I just share your email addresses in that as well, that people could contact you directly.
Thank you very
Awesome.
much. Yes, thank you, everybody, so much.
Okay, everybody, have a great rest of your day.
Thank you. You too.
Bye-bye.
Bye. Stay
Bye.
well.
Okay, bye. Thank you. I'll be ready.
Bye, Sarah.